Good morning, everyone, and thank you for joining us today. My name is Andrew Gangemi. I'm a assistant professor of medicine at Temple University in Philadelphia, Pennsylvania. I'm joined by my co-host, Dr. Raymond Chad Wade from the University of Alabama. We're members of the ATS Clinical Problems Webinar Committee. Today, our journal club is focused on the recent publication Geographic Disparities by Rural Urban Status and Drive Time to Care and Tobacco Treatment for COPD. We're joined by two authors from the study, Dr. Arianne Baldomero and Dr. Anne Melzer. Both are professors of medicine in pulmonary, allergy, critical care, and sleep medicine at the Minneapolis VA healthcare system and also at the University of Minnesota. We're joined by some very esteemed colleagues as well, who are very active with tobacco cessation policies with the American Thoracic Society. So I'll introduce them in alphabetical order. We have Michelle Eakin, who is a professor in the Division of Pulmonary and Critical Care Medicine at Johns Hopkins University in Baltimore, Maryland. By my colleague, Dr. Jamie Garfield, who is professor of thoracic medicine and surgery at the Lewis Katz School of Medicine at Temple University of Philadelphia, and also by Dr. Adam Lang, who is with the Department of Family and Community Medicine at Virginia Commonwealth University School of Medicine in Richmond, Virginia. So at this time, Dr. Baldomero, Dr. Melzer, I'll invite you to begin.
Thanks. I think I'm starting out here. So good morning, everyone. So our objectives today, we're going to review current evidence and guidelines around tobacco treatment. Oop, you can go to the next slide. You're controlling it, Arianne. Is that correct? Okay. We're going to talk about the provision of tobacco dependence treatment among patients with COPD and then examine the associations in rural urban status, drive time to care, and receipt of tobacco dependence treatment. Next slide. So I'm going to breeze through some of these background slides pretty fast because I think hopefully I'm preaching to the choir here. So why is tobacco dependence treatment so important in COPD? Obviously, most cases of COPD are attributable to tobacco smoking in the developed world, and it's the primary modifiable risk factor for both disease onset and progression. Next slide. And so again, why, what does it matter? The more people smoke, the more pack years they accumulate, the more severe COPD tends to be, including particularly the risk of exacerbation. Next slide. And so, in many ways, tobacco dependence treatment is the most important intervention for patients with COPD who smoke. And so failure to treat tobacco use is really a missed opportunity to reduce morbidity, mortality, and cost. Next slide. Sorry, this is showing kind of funny. So evidence-based tobacco dependence treatment, kind of per whatever you look at, Cochrane reviews, guidelines, is, sorry, it's displaying kind of weird. I'm trying to make it bigger so I can see. One moment. If you utilize kind of the gold standard tobacco dependence treatment, which is a comprehensive combination of pharmacotherapy and behavioral counseling, you see that people have improved outcomes kind of in terms of whatever way we measure them in terms of comparative risks and outcomes. Go ahead, next slide. And when we look, pulling from that Cochrane review at all the different types of tobacco dependence treatment that we offer, which includes nicotine replacement, combination nicotine replacement, and each of those therapies alone, as well as varenicline and bupropion, we see that, varenicline continues to sort of come out number one, compared to all the other treatment options, which, as you'll see from some of our data, is a little bit concerning because it does not actually tend to be one of the most heavily utilized treatments, and yet we know it is the most efficacious, and this is mirrored in the ATS tobacco dependence treatment guideline.